Welcome everyone for what I understand is the last session of the day on the health and well-being stage. As Jack was saying, we're going to discuss the Charter for Health for post-COVID-19, or how will COVID-19 change the social contract between citizens and the healthcare system. My name is Andreas Haimboeck-Tichy. I'm the Director of Life Sciences and Healthcare for IBM here in the UK. And to help me discuss this topic, I'm joined by four fantastic panelists. Tracey, Cottam, Director of Transformation at Devon and Exeter. Natalie Leeds from Wellcome, Lead for Understanding Patient Data. Mark Davies, Chief Medical Officer, IBM in Europe. And then Vahdat, the CEO and founder of Huma. The way we're going to structure this is that each of our panelists will give us a point of view from their perspective, and they'll have an opportunity to introduce themselves a little bit more as part of that. And first, we thought it would be useful to hear from somebody who's living the COVID pandemic from the front line and what that means going forward. So I'd like to introduce Tracey Cottam, who's got 40 years experience in industry and healthcare. As a senior leader at large-scale transformation programs, engaging in stakeholders, cultural change, redesign of operation and clinical services. She's currently the executive team member at the Royal Devon and Exeter NHS Foundation Trust. There she's is responsible for transformation and stakeholder engagement. Tracey, if I can hand it over to you, please.
Thanks, Andreas. Good evening, everyone. So we're living in quite an odd time, aren't we, during the COVID-19 pandemic? I guess for the NHS, it's a situation that we have planned for. We were planning for something that we thought was going to be extremely difficult, and it still may be very difficult. But out of adversity comes opportunity, and the pandemic has driven a need for the NHS to innovate. What does that mean? We've had to change how care is delivered. We've had to radically remove traditional boundaries between professions, particularly medics and nursing and therapies. We've had to change the traditional norms of how care is delivered. And we've had to introduce to patients, staff and public different ways of interacting with each other. This change had to be delivered at a really fast pace. And what's been essential to achieving this has been about creating the right conditions for delivering care in a very different way. So what does that mean? Well, for us in Royal Devon and Exeter, we've had to create a singular shared focus for everyone. And that means we've had to remove competing agendas or demands. We've had to remove the red tape around bureaucracy and give our teams greater freedom to innovate and make decisions. We've had to make fast decision-making easier. So we've removed the need for lengthy papers to be produced and for numerous levels of approval. We've had strong and consistent leadership, and that means we've had common messages, a clarity of focus and consistent behaviours. And what's been really important is to ensure that every member of staff, patients and members of public have felt informed and supported throughout. And that's been about doing daily communication every single day. And we've proved to ourselves, to patients, to members of public, that there is a different way to deliver care. And actually technology has been essential to achieving this. Where are we now? Well, the reality is COVID-19 is going to remain with us for the foreseeable future. Essentially, we're seeing it as another condition that we have to provide care and services for. However, what's also evident is that we also need to recover other services too. Our current level of COVID-19 in Devon is relatively low. It's certainly not at critical incident level. But what is really important is that we start to open up other forms of care that are required by our patients and the public. As we continue to manage COVID, we will seek to recover a full suite of services, but throughout, what's paramount to us is continued safety of patients and staff. So we're watching every single day how COVID is developing. We have to achieve benefits out of the innovation. And so we are now looking actively at all of the changes that we've made, which can we and should we sustain? And we kind of now need to create a new norm, and we can't revert back to the previous way of delivering care and services. The continued restrictions around social distancing will continue to drive a need to continually deliver services in a different way. But even without that driver, why would we go back to old and inefficient ways of delivering care? Our staff don't want to do that, and more importantly, nor do our patients. Thank you.
Thank you, Tracey. That was a great start to this discussion. I'm especially curious to come back to you and ask a bit more around how we make sure we don't go back. But we'll keep that for after when we've heard from the other panelists. So I'd now like to invite Natalie Barner. So Natalie leads Understanding Patient Data, an initiative hosted at the Wellcome to make uses of health data more visible, understandable, and trustworthy. This includes exploring how to ensure governance, policy frameworks for data-driven technologies are responsive to public views and values. Prior to joining Wellcome, Natalie was postdoctoral research fellow in philosophy at the King's College London. So Natalie, if you could give us a view from a patient-centric data perspective.
Thanks very much, Andreas. And it's a pleasure to be here. Thank you for the invitation. So as Andreas said, I look at this context of COVID-19 through the lens of data and health data, patient data, which is obviously being absolutely critical to the public health response. Questions around data use, how it's managed and used, have been around for a long time. There's been lots of exploration about what's acceptable and what's not. Attitudes and engagement research that's explored how people think about data-driven technologies, who we do and don't trust with our data, and so on. But I think it's fair to say that COVID-19 has really brought the use of data into sharp focus for patients and the public. Suddenly, data is in every single press briefing we're seeing, and huge, public health and policy decisions are being made on the basis of the numbers that are being generated across the country. Suddenly, there are questions of benefits and risks, how we're making decisions within perfect knowledge and understanding. Trade-offs are incredibly prominent and tangible, and also the balance between individual rights and responsibilities and the societal duties of care and protection are suddenly much, much more prominent and visible in the public mind. And it's interesting, from someone who's done a lot of attitudes research in the past, we suddenly have these perfectly formed case studies emerging with really interesting contours around where the edges of acceptability lie for people when it comes to managing and using data. Typically in attitudes research, it takes a long time to get people to understand what we mean by data and how it's managed and how it's used before you can explore what people find acceptable or not. But suddenly we have these great examples that are very meaningful and tangible to people they can instantly engage with. For example, how the shielding list was generated, and on the one hand saying, okay, well, it's acceptable to create this list so people know if they're being classed as vulnerable and should shield for several weeks, but then is it acceptable for that data to then be used by supermarkets to prioritize shopping deliveries for the most vulnerable? You suddenly got these very, very clear examples that resonate with people on a personal level. But the questions and concerns that are arising around the use of data are not necessarily new. In a sense, they are the sorts of questions that have been around for as long as we've been trying to manage and use data to improve healthcare and services through research and planning. So questions around, well, who's actually using data? Where is it going? What's the purpose of using this data? Are there commercial interests involved? If there are, what is the business model behind them? Is there a risk that we and the health services are being exploited because we're in a crisis situation? And what's the long-term vision for how the data that's being collected in the context of the public health crisis might be used in future? And I think that's really crystallized with questions arising around the test and trace program, particularly the contact tracing app, which I know has been a big topic of discussion throughout CogX today, particularly on the ethics stage that the Ada Lovelace has been managing. Questions about what's actually happening to the data collected through that app are very pertinent, and they're very prominent in the public mind. And critically, if those questions go unanswered, then matters of public trust absolutely come to the fore. If you don't trust what's happening to your data and how it's being used, even if there is a big public health benefit there potentially, if you don't trust what's happening to that data, you might be reluctant to engage and involve and actually participate in some of the what's necessary for the public health response. So I think this question of trust is going to be absolutely critical if we are thinking about, what healthcare looks like, whether there is a new, as it terms, social contract between individuals and society for the management of health, public health in particular, in the long term. The issue of trust is absolutely critical. And we talk a lot about trustworthiness rather than trust, because we think it's critical that the system that has been developed for managing and using data demonstrates clearly, critically, how it is worthy of the trust that it is asking people to put in them. Partly that comes down to being really clear on the ability to manage and use that data safely, the competence that those using and managing data have to protect it and ensure it is safe and secure, but also motivation and fairness. What's in it for you, whether you're a commercial entity or you're part of the public health system? Are there different government departments, for example, that might really like to be able to use that data? We have to be very, very crystal clear with people what's actually happening in practice. But critically, in the midst of a crisis, we need to understand what new norms, new policies, new processes, new infrastructures might be being developed now that are going to continue to have long-term implications. It's not necessarily the case that we're setting up various initiatives such as the data store and the contact tracing program, and they will just disappear once the public health crisis is over. As Tracey said, we don't necessarily want to go back to old ways of doing things. But if we are going to be building new ways of collecting, managing, utilizing data for public health and for public good and in the public interest, we need to think very, very carefully about what's being set up and how, and critically ensure that the public views and values and the diversity of those views and values are embedded. Or if they don't, then we're not going to have social license for this kind of technology and this kind of data use in the longer term. We produced a report back in March called The Foundations of Fairness that explored how people feel about the NHS working in partnership with third parties when it comes to data. And the critical things that came out there were around transparency, accountability, and crucially, diverse public involvement in setting up and managing and deciding what actually happens to data in the long run. And the thing I want to sort of close with is this idea that we have established mechanisms of public and patient involvement and engagement, but I personally don't think they are good enough for really thinking into the long term and thinking about the future here of data use. The Public Health England disparities report published last week, the horrendous events of the last couple of weeks in America, but also here, the protests we're seeing around disparities and discrimination against ethnic minorities. We cannot rely on established methods of PPIE to ensure that we're getting a diversity of views into the discussions and the debates around how data is managed and used. We do not have the diverse range of perspectives we need to really be building a system that is going to have the full trust and trustworthiness for the broad public and in all of its diversity. So that's just I suppose the thing I'd want to end on is we need to think very critically and very carefully if public views really are being represented in the kind of norms and cultures and institutions we're creating around data right now. Thanks very much.
Thank you, Natalie. And again, I think you finished on a couple of points, maybe one or two questions later in terms of, as this was happening in such space, how we make sure that in the next step we really get broader stakeholder engagement and a diverse group engaging in that. So with that, I'd like to move on to Dr. Mark Davies. Mark is the Chief Medical Officer for IBM in Europe. He's been a practicing GP for 25 years in Yorkshire, where he still lives, and has worked in government as well as in the NHS in various clinical roles, including being the medical director for what is now NHS Digital. So Mark, I'd like to invite you to talk to us about post-COVID from a clinician's perspective.
Thank you, Andreas, and good evening, everybody. I've been asked to talk about this from a clinician perspective, but actually I prefer to use the term professional caregiver, because what I'm going to say around doctors and nurses and other healthcare professionals is equally true of those who work in social care and other professional caregiving roles. I think we've all been staggered by the levels of professionalism and personal bravery that we've seen in staff in health and social care, and I think the expressions of public support and public gratitude pay testimony to that, and I think have permanently changed the relationship between those professional caregivers and the population. I'd like to talk about three things that have been most prominent, I think, for most professional caregivers, and the first of which is around PPE, so personal protection equipment, and the necessary physical barriers that we have to protect staff from patients and patients from staff. And if you can imagine that actually the currency of clinical care is around communication and human connection, imagine how hard that is through a visor and indeed a mask and a whole bunch of head covering. Sometimes clinicians are involved in difficult conversations, and the art of medicine is how you marshal those conversations in a way that is respectful and meets the needs of the person that you have in front of you. In fact, the motto of my own Royal College, the Royal College of General Practitioners, is science with empathy, and it sees both those things as being equally important. We are we are heralding a time where there is a new form of consultation. Most of general practice has moved to an almost entirely virtual platform now, whether that is patients on an intensive care unit on either sides of a infection control barrier, end of life units, either in hospices or in hospitals, care homes, or indeed district nursing, out there visiting people in their own homes. The challenges of communication in this new kind of world that imposes a physical distance is creating a redefinition of some of the art of professional caregiving. The second thing I want to talk about is this incredible situation where since the history of the NHS, we have had more people coming to see us than we could deal with, and that situation has been reversed in a matter of weeks, and we have seen, I suspect, an irreversible shift towards us as citizens taking more responsibility for keeping well and more responsibility for managing our own health. That shift towards a more self-service model of healthcare is positive, in the sense that we are looking at a more participative form of healthcare moving forwards, where people aren't passive recipients of professional care, but actually become equal partners in defining their own goals, objectives, and outcomes of care. But we should not forget that 50 years ago, next year, in fact, a general practitioner in South Wales called Tudor Hart came up with the inverse care law, which described that those most in need of care were the least likely to have access to it. And I think 50 years later, that situation has not changed. And it is a profound worry, I think, for all of us from a clinical perspective, that we may be entering into a world where, in fact, those health inequalities may be getting worse, and that inequality may be accelerated by COVID. And the third thing I would say very briefly is to just reflect on what we have asked professional caregivers to do over the last few weeks and months, and they have had to manage things that they were never professionally trained to deal with, unprecedented levels of emotional stress. They've been asked to manage a disease where there was a great deal we don't know about in terms of its natural history, and on top of all that, exposed themselves to significant personal risk for them and indeed their families. And I think moving forward, we will need to have an increased focus on the mental health and the mental well-being of those who we ask to take a caring role professionally for us, if we are going to have continue to have a sustainable care system. So in summary, I would describe the future contract, if that's what it is, as being more personal, more participative, because it needs to be, fundamentally more integrated, and inevitably more digital.
Thank you, Mark. Thank you very much, Mark, and thanks for setting me straight there and actually inviting into all the caregivers, which are absolutely correct. And again, I've got one or two questions, especially in terms of how we deal with the emotional, the personal side of the new world in a little while. Last but by no means least, I'd like to invite Dan. Dan is the CEO and founder of Huma, a global health tech AI company headquartered in London with offices in New York and Shanghai. Huma's vision is to create a world where we can all live our longest and fullest lives. Dan was awarded CEO of the Year at WebIT 2018 Global Summit, and his PhD is in bioengineering from Johns Hopkins University and the University of Oxford. I know, Dan, you've been doing obviously work in the UK during this pandemic, but also elsewhere. So it'd be good to get a business perspective, but also something a bit further afield, maybe.
Sure, thanks a lot. I guess as a little bit of corrections, I never finished my PhD, made my father very upset, left the school, started the company a while back. In terms of what we saw, and I think the opportunities that COVID-19 has brought to the industry is just speed. Give an example. I think projects that would have taken us years to sign, we managed to not only sign, but also deliver it in a matter of weeks. One of our most recent partnership that was in the news yesterday and last week, which we had Simon Stevens, CEO of NHS, visiting one of the sites, is around COVID-19 monitoring and how we can use technology to look after patients when they're quarantined at home and pick up the complications remotely. And from the signature to go live, it was a matter of days. And we are now live in more than 6 sites. Pretty much every week we are rolling out to new sites with phenomenal adherence from the patient side as well, 90+% adherence to the technology. And as a result of that huge amount of impact, which is just the beginning, because this kind of technology, remote patients monitoring, can become relevant for any high-risk patients, any chronic disease patients. And I think COVID-19 kind of accelerated the adoptions and the thinkings and the mindset, and other panelists also highlighted about the impact. And from the, when you talk to the patients, we had the patients that they started writing to us about the impact of this. It also works for them, because suddenly you have not only a connectivity that potentially more intimate, given the workload of NHS. As you all remember, you would go and see doctors, and you had to go to the next ones, and the doctors had to see another patient after you. So in that sense, I think it has changed the mindset of healthcare providers, changed the mindsets of the patients, but also perhaps the payers and governments that these kind of technologies can work and can scale really fast, and it doesn't require big investment, and it can be implemented in an effective way with quite like a clear ROIs. And there's a publications on BMJ on one of our projects we did, and the hospitals published it themselves on the monetary impact that it can have. So that's kind of the view we have seen that COVID-19 has brought, and that impact hopefully will stay afterward. To summarize, the speed that now healthcare systems are moving to make good decisions, the convenience and the simplicity of the interactions and delivery of care through technology, and the last one is the financial impact on the savings and ROI, which I think all three of those could stay with us, hopefully.
Very good. Thank you, Dan. I can see a couple of questions already coming in from the people watching our discussion here, but maybe one or two for me to kick us off here. So, Tracey, you spoke about the fact that you were able to put the right conditions in place and remove barriers, and then we're now in a situation where we need to create a new norm, and it's important that we don't go back to the old, or at least not for the things we want to hang on to because they're making a difference. So what do you think needs to happen for us to ensure we don't go back?
I think at a national level, I think the NHS needs to reflect on the last 2 to 3 months. Some of the assurance that the centre requires from all health providers, some of it is absolutely necessary. Some of it could be provided in a very different way, particularly if we invested in digital technology. We could get much better access to real-time data in a much quicker way. So I think there's a whole set of things that we need to do at a national level. I think at a local level within each organisation, every trust will have had a very similar experience to Royal Devon and Exeter. I don't think we're unique. There will be numerous examples where teams will just have found a better way in delivering care and services, and we need to really hold back from putting back all of the checks and balances and the red tape, as we call it at RD&E, that kind of stifle them and put kind of handcuffs around them. And I think a really strong learning for us is that the work that we did around just removing all of the barriers and rules and governance structures, we made sure that we were safe, we made sure that patients and staff were safe, but actually we allowed and created freedoms for our people, and they really stepped up. And the feedback that we're getting from our staff is that they loved that time. They loved the experience of being able to make improvements and changes in a really fast-paced way. And they're desperate that we don't go back. And I think we owe it to them. I really do. And we owe it to our patients and to the public. So I think there's a whole host of things that we can learn from.
Very good. Thank you, Tracey. Natalie, if I can come to you, and you alluded that trust is very important, and a lot of the measures that have been put in place over the last couple of weeks, months, maybe have not had the opportunity to be consulted as widely as we would do in normal times. So, and you also pointed out that the way things are most probably not robust enough for going forward. So can you talk about how you feel the engagement of the patients and the wider group needs to happen going forward. Have we lost Natalie?
I don't know if we have. Oh, we are.
Maybe.
Andreas.
Yes.
Oh, we're going to move to the Q&A. So we're going to draw the conversation here to a close and shift over for those people who are priority pass holders to continue the Q&A, if you don't mind, on the breakout Q&A stage. Because the chariot has turned into a pumpkin, or whichever way around it's supposed to be, and we have reached the end of this this session. So is that okay? I can't see anyone else on the screen right now. Is it just you and I?
It's it's okay by me. I don't. I can only see you as well, so I don't know what happened to the others. But
well, we can't see.
Then
the others. Okay,
I'm not the technology expert. So I'm hoping the others do.
All that's left for me to say is just thank you very much for everyone who's listened. I didn't want to break this out, break up the conversation halfway through these very interesting questions and answers. But if you guys stay on the line, I'll leave and just say thank you very much for everyone that's listening. Andreas, thank you very much for moderating this last panel, and good luck with the rest of the questions. And see you everybody else tomorrow. Good night.
Lovely. Thanks, Jack.
Want access to more CogX videos? Subscribe now for free at cogx.co.